We're normally very good at dealing with infection, but for whatever reason, some patients get this exaggerated, dysregulated host response that actually then triggers the body acting against itself, and the organs start becoming dysfunctional, failing, and then the patients become critically ill and potentially at very high risk of dying.
Welcome to Healthcare Perspectives, a podcast by Siemens Healthineers about medical breakthroughs with the power to improve lives everywhere. You've just heard Mervyn Singer, Professor of Intensive Care Medicine at University College London, explaining what happens when the body develops sepsis. In this episode, Ranga Sampath, head of the Center for Innovation in Diagnostics at Siemens Healthineers and member of the board of the Sepsis Alliance, is joined by Professor Mervyn Singer as well as Patti DeJuilio, Director of Respiratory Care and Diagnostic Services at Northwestern Medicine Central DuPage Hospital in Winfield, Illinois, Dr. Eric Gluck, Director of Critical Care Services at Swedish Hospital, and Professor of Medicine at Finch University of Health Sciences at the Chicago Medical School, and Heike Spreter-Krick, a sepsis survivor who is now a patient advocate working with the Global Sepsis Alliance.
Hello, I'm Ranga Sampath. Sepsis, once known as blood poisoning, is the body's extreme response to an infection. It is a life-threatening medical emergency that occurs when an ongoing infection triggers a chain reaction throughout a person's body. It can be difficult to diagnose because patients present differently and patient observations can be subjective. The condition also poses a significant global health challenge with serious implications for mortality, long-term morbidity, and healthcare costs. According to the Sepsis Alliance, sepsis contributes to approximately 1 in 5 deaths worldwide. In the United States alone, it stands as the leading cause of death in hospitals, leading to 1 in 3 hospital fatalities. Further compounding these mortality rates is a rise in antibiotic and antimicrobial resistance, or AMR, due to overuse or misuse. In this episode, experts in the field of diagnostics and critical care, as well as a sepsis patient and advocate, will help us more acutely understand the disease, its identification and diagnosis, and the advancements being made in the field.
I decided to quit my job in 2021, and because I love the mountains and nature, I decided to do an alpine job in the Swiss mountains, making cheese and milking cows. We had no electricity except for milking. Otherwise, the hut was only heated with wood, and therefore, because we had 4 weeks of cold, rainy weather, it was clear to me that I would get a cold at some point.
That is Heike Spreter-Krick, a patient and patient advocate whose sepsis battle began in 2021 with a common throat ache.
Then I started with swallowing difficulties and didn't think anything of it at first. What was strange for me, however, was that the swallowing difficulties were always equally bad. They were so extremely bad that I wanted to turn off the normal swallowing reflex. On the second day, I got the chills. I had not known that you could shiver and freeze so uncontrollably. I fell asleep every now and then that day. I was just lying in bed. I couldn't get up at all. And on the third day, I had pain in my left upper arm and could no longer stand and walk on my left leg because of the pain. I can't remember what happened after that, because I then became unconscious.
After losing consciousness, Heike Spreter-Krick was transported by a helicopter by the Swiss Air Rescue Service to a hospital in Lucerne.
I don't know anything about the treatments during the first 5 days. Well, I don't have any memory. I have individual impressions, although I don't know whether it really took place or not. Of course, I know something about the other 5.5 weeks, about the operations and treatments. However, it was simply not clear to me what I had. I don't remember anyone saying sepsis to me, which doesn't mean they didn't say it. But I lived in a bubble where I just participated.
According to Patti DeJuilio, Director of Respiratory Care and Diagnostic Services at Northwestern Medicine, Central DuPage Hospital, timing is incredibly critical when identifying and triaging patients suspected of sepsis.
Patients with sepsis have lack of oxygen in their cells. And so the more time we spend diagnosing and understanding and then treating the symptoms of sepsis, the more cells that are going to die.
When a patient contracts a sepsis infection, it is the body's particular response that dictates treatment as well as prognosis.
This is bad enough to put you in hospital and often in an intensive care unit. If your lungs have failed, you may need ventilatory support. If your cardiovascular system's failed, you may need drugs to help elevate your blood pressure, improve your cardiac output. If your kidneys have failed, you go on a kidney machine. Unfortunately, this broad spectrum of problems, even survivors can have long-term cognitive, physical, behavioral problems directly as a result of being critically ill.
But there are specific risk factors that may also play a role in a patient's experience with sepsis.
Extremes of age. The good thing about small children is they generally tend to be quite resilient, whereas as you get older, even healthy old people, the immune system doesn't work as well, but they've often got lots of comorbidities, heart problems, lung problems, kidney problems, and they're often on lots of different medications that may muddy the picture. If you're immunosuppressed, so patients who are having cancer therapy or on steroids, they've had organ transplantation and they're on immunosuppressant therapies there. Diabetes is a risk factor. Loads of things. Coming into hospital and having an operation is a risk factor because problems can occur post-operatively, wound infections and the like. So there's this whole list of factors.
For Heike Spreter-Krick, a childhood bout with cancer that left her without a spleen led to her increased susceptibility to sepsis.
I had cancer in 1986 and had my spleen removed. Unfortunately, I was never told that life without a spleen is a risk factor and that I am more likely to get sepsis. I now have a passport. It's called Aplamy. I read it in retrospect. If I had read it better beforehand and dealt with it, maybe I would have reacted differently on the alpine pasture.
So about 50 years ago, my predecessors came up with some criteria to diagnose sepsis. It was the best they had at the time, and they thought they worked. As it turns out, they're not very sensitive and not very specific. And so it's not so easy to diagnose sepsis.
In Chicago, Dr. Gluck works as the Director of Critical Care Services at the Swedish hospital. For his team and others like them, sepsis diagnosis presents several unique challenges.
The organisms that are invading us are not cooperating. They're not so easy to grow in cultures, so identification of them is very difficult. We have a tough time with diagnosing sepsis. We don't want to miss it, because missing sepsis is a big deal.
Because sepsis presents differently in patients, healthcare providers use a variety of tools to aid them in diagnosing a patient with sepsis. Like Gluck, Mervyn Singer in London gives preference to specific physical and visual cues from patients in addition to lab tests when diagnosing sepsis.
I'm still a great believer in the good old-fashioned talk to the patient if they're not able to give you a clear history, confusion, drowsiness, agitation, then hopefully a family member or somebody in the care home can give a story as to how they've been progressing over the last hours or days. Look at their medication, their past history, and then a good examination. Is there anything to suggest the infection's in the abdomen or the brain or the lung or the kidney or whatever? And then you send off your array of tests, and these can be the straightforward lab tests that you do, the hematology, biochemistry, etc. You take appropriate specimens for microbiology. So blood cultures obviously is a standard thing, but you may want to take cultures of an organ that you think may be affected.
This more traditional examination, he says, can work cohesively with other comprehensive imaging and lab tests.
Now we've got point of care testing for ultrasound, echo, standard x-rays, chest x-rays, etc., CT scans, if need be MRI. So there's this whole panoply of imaging tools that are now available to help try and work out what's going on with the patient. And that might obviously help guide the diagnosis. And then increasingly, we're using more and more molecular biology tests. You're trying to put together all these different bits of the jigsaw and then hopefully get a clear picture that, yes, this is an infection, this is the type of bug. Increasingly, there are techniques to try and work out if that bug is susceptible or resistant to a particular antibiotic. So if you can put all of these things together, and clearly the sooner you get the right answer, the quicker you can give the right treatment to the patient and hopefully enhance their chances of recovery.
For Eric Gluck in Chicago, procalcitonin test has become an indispensable part of his sepsis diagnosis arsenal. Procalcitonin, otherwise known as PCT, is a biomarker released by the body in response to bacterial infections. Commonly known for its role in the body's processing of calcium, over the past few decades, it has also been identified for its use as a signal of bacteria in the body.
When bacteria interact with the cell, they interact with these receptors on the outside of the cells called toll receptors. It causes a chain reaction of events that causes the production of procalcitonin in the cell. That is released. It stays locally for a while the body determines whether they can handle the infection without further intervention by other parts of the body, and then it eventually leaks into the serum, and that typically means that we have a non-contained bacterial infection. Only bacteria cause the release of procalcitonin.
Through the measurement of PCT levels in a hospitalized patient with sepsis-like symptoms, non-bacterial sources of infection can often be ruled out.
For instance, during flu season, a lot of people come in and they have an influenza infection. They look septic, just like a bacterial infection, but they're not. So the clinician would use it sometimes to differentiate between a bacterial infection or a viral infection.
Though PCT testing has proven to be game-changing at Swedish Hospital, there was an initial caution before widely implementing the technique.
We started out in the intensive care unit, very controlled environment where people could be very easily educated about how to use procalcitonin appropriately and how to incorporate it with the other tests that we had. We basically did procalcitonins on every single patient that came in, and then we looked at the ones who were definitely infected, and we looked at procalcitonin levels. And then once we were convinced that it worked in the ICU, we then went to the next most important place to identify infection, which is in the emergency department. Once we had a good handle on how to use it, we then allowed it to be used throughout the hospital.
And one of the biggest challenges in having integrated PCT testing was the reluctance of fellow physicians.
To be introduced with a new biomarker was a little unsettling because it sort of implies that maybe what we were doing before was not as good as we thought it was. And then couple it with the fact that procalcitonin was a hormone that was going to regulate calcium. And now it is related to this completely unrelated subject, the sepsis.
Elsewhere in the greater Chicago area, Patti DeJuilio and her respiratory care team at Central DuPage Hospital have embraced a different biomarker complementary to other test results that help indicate potential for sepsis.
So picture that a patient arrives to our emergency department. They're seen by a triage nurse. The triage nurse is now inputting information into our electronic medical record. We have alerts built that trigger a sepsis alert. And so all these parameters, vitals, show that this patient is possibly sepsis. So that alert goes out to the respiratory therapist at my hospital. We arrive and we can run a lactate then right away. Time is of the essence when it comes to a lot of different diseases, but sepsis especially.
For healthcare professionals, the elevated presence of lactate, a chemical naturally produced by the body during times of stress, is one indicator that a patient may be experiencing sepsis.
Lactate is the earliest clue that we have to cardiovascular compromise. The body responds to bacteria in the blood with inflammation to start, and it changes the levels of certain enzymes in the blood. And so lactate, it's the only parameter that can be drawn to tell us that sepsis is probably occurring with this patient. And it also can predict outcomes for the patient. And then we do subsequent lactates now to tell us that the treatment that we're giving the patient is working as expected. The faster you can get the result, the quicker you can start the blood draws that need to occur, the blood cultures, the antibiotic, and eventually the treatment for the patient.
Patti DeJuilio saw the opportunity for lactate testing at the point of care to support her institution's tightening sepsis guidelines.
We had a goal set that when a patient arrived to the emergency department that we would actually have a lactate resulted within 30 minutes for those patients that showed signs and symptoms of sepsis or sepsis shock. I couldn't believe the outcomes when we initially saw them, but truthfully, when we think about how many brain cells we have saved, it's unbelievable. At the end of the day, we want to save lives, but we'd also like to see patients go home as they were before coming in. We want people to have a really, truly good outcome so that they don't have any deficits from oxygen loss to the brain that occurs with sepsis.
Of course, even with advancements in the diagnosis of sepsis infections, the very best medicine is prevention, says Mervyn Singer.
The golden rule is look after your body, which goes without saying. So if you've got diabetes, the better the control of the diabetes, the lower the risk. And obviously you don't get the other problems with diabetes like gangrenous feet that can become infected. Don't abuse your body with too much alcohol. Again, cirrhosis causes immune suppression.
In the UK, a nationwide program is already in use to closely monitor patients who are at risk for developing sepsis.
We have a national early warning score implemented in the emergency department, the wards, the paramedics now using it, nursing homes, increasingly family doctors, which is a very simple bedside 7 things you measure: the blood pressure, the heart rate, the temperature, if they're confused or drowsy. It's just saying something's wrong with the physiology. It doesn't necessarily mean it's infection, it could be something else, but at least it gets a sick patient to hopefully the right clinician early on. And then obviously you can look at the trajectory, hopefully get the right diagnosis, give the right treatment.
Though Mervyn Singer cautions against misusing the emergency department for minor illnesses, he also stresses the importance of monitoring your own symptoms.
If you're deteriorating, you're becoming more breathless or more confused, you're finding you're not passing enough urine, these are signs that maybe the organs are beginning to struggle and become dysfunctional. That's the time you need to present yourself to the doctor and say, hey, I'm not well. Can you please find out why?
For those who end up with infection and sepsis, the use of intravenous antibiotics has long been the gold standard. But there is risk attached to these drugs.
Most of my colleagues believe that giving antibiotics is a less risk to the patient. There are, though, risks involved in giving antibiotics to patients who don't need them. And so it becomes almost an anxiolytic for the doctor. When a patient appears to be septic, let's just give them antibiotics and that will be the easiest way to deal with the potential for the patient to decline and for me to have a better night's sleep, not worrying that I missed something in the hospital.
Mervyn Singer says the issue with overuse of antibiotics comes when microbes evolve to develop a resistance to the very drugs designed to kill them. In recent decades, the idea of AMR has become a significant concept in the medical world.
If we can be smarter in how we use antibiotics, we'll cut down on the AMR type of issue. Antibiotics do carry a whole load of covert side effects. They can affect your immune system, your mitochondria, your organ function, kidney, liver. You can get rashes, loads of things that they do. Your microbiome, which is increasingly recognized to be incredibly important. And that's what we throw around like Smarties.
And for sepsis treatment to be effective, patients and physicians need those antibiotics to work as they are intended.
treating one patient's not going to make any difference to AMR worldwide, but if you extrapolate that to every doctor and every patient being treated, it's a lot of antibiotics that are being abused. So you've got that issue. And so if it's a virus, sometimes viral infections can get secondary infections with bacteria. But if you're confident it's a viral infection, they don't need an antibacterial antibiotic.
And for Eric Gluck, reducing the overuse of antibiotics has been just one benefit of implementing PCT testing.
Because my colleagues in the emergency department are under a time constraint, a lot of patients have started on antibiotics. And some of those patients come up to the intensive care unit. And then when we had more data, we're looking at these patients and we're saying, I don't know, doesn't look like they're infected. We would do another procalcitonin level in the ICU. And if we had 2 negative procalcitonins, we stopped antibiotics. In a study that we published, we were able to reduce antibiotic usage in those particular patients by 50%. So 50% of the patients who came up to us from the emergency department on antibiotics, the antibiotics were stopped within 24 hours. One of the things that we have found very useful is monitoring the patient's response to procalcitonin. And so not just getting the measurement on the day when the patient presents, but looking at the response so that we can individualize the number of days of antibiotics that a specific patient might need.
For sepsis patients like Heike Spreter-Krick, surviving infection is just the beginning of a long road to recovery.
The long-term consequences can be felt all over the body, but I still feel the long-term consequences of this sepsis every day, even though it's been almost 3 years. My heart is damaged, my heart valves are damaged, my feet are scarred. I have skin problems due to the adhesions from the scars, from the necroses that I had. What can always happen, of course, is that you have post-traumatic symptoms, post-sepsis symptoms, that you are tired, that you are weakened, that you have difficulties concentrating, that you are no longer as capable to comprehend. For example, sometimes I just can't remember words. Memories from the past are gone for me. Maybe that is caused by the strokes.
And though she has long since returned home from her extended stay in the hospital, she's not yet out of the woods and continues to receive several regular tests and therapies.
I still have regular visits to the doctor. I have been measuring my blood pressure regularly for the last 2 years. I took my temperature. The blood was tested every 2 to 4 weeks to see if the inflammation level was within the normal range. I've had rehab, inpatient and outpatient. I'm still in physiotherapy. I am at the sports cardiology department. I have psychotherapeutic support because I just can't wrap my head around that this happened to me. You can't say, as in the case of a broken leg, that the bone heals and then you can do everything again.
In the UK, sepsis survivors with complications, like Heike Spreter-Krick, can receive treatment at specialized clinics.
Many hospitals do it. Because these patients have multiple problems often, they can be cognitive, behavioral, psychiatric, physical, that your family practitioner wouldn't necessarily understand. So the idea with the survivor clinic, in our hospital, we have a doctor, a nurse, a psychologist, and a physiotherapist. They don't have to come back, but they can come back and talk about their issues, their problems, and it can be explained to them that this is actually quite normal, etc., coping mechanisms or referrals. So if they have hallucinations, whatever, you might be able to help with that. Post-traumatic stress disorder is not uncommon. They may have muscle weakness or nerve weakness that goes on for a long time. So again, exercises to help build up muscle strength and movement. Often these patients are stuck in bed for days, weeks, sometimes months, and you've got to get them mobilized, you've got to get muscle bulk back on. If you can direct the patient and their family, their carers, towards actually trying to optimize their recovery, and certainly the first few months are the most crucial. So if you can try and institute that early in a survivor, hopefully you'll minimize their long-term disabilities.
For Patti DeJuilio, capturing an earlier picture of relevant biomarkers at the point of care, alongside other clinical findings, supports earlier intervention.
The sooner we get results, the sooner we can respond. And this is true even for patients on ventilators, changes that we make, changes to therapies that you make, and you want to see the response. Our subsequent lactates, now we can really quickly understand whether the antibiotic is appropriate, whether we need to change something, because we expect the lactate to quickly be decreasing if we have the right antibiotic on board. Time saved is tissue saved.
Top of mind for Eric Gluck is how testing might evolve to support antibiotic decisions in the future.
It should be available outpatient. This could be really useful in pediatric offices, perhaps. The children present with gastrointestinal illnesses and sore throats and things like that, and the pediatrician is often trying to figure out, is this a virus and we don't need to give antimicrobials, or is this really a significant bacterial infection?
For Mervyn Singer, there's a huge future potential for wireless and remote monitoring to reduce the occurrence of sepsis in patients who aren't currently in the hospital.
Wouldn't it be better if you can pick up the patient early and be preemptive rather than wait for them to become ill? It's already being introduced to some degree in pulse oximetry. In the UK, we use COVID as an example. Patients who came to hospital, weren't sick enough to be admitted, were sent home with a pulse oximeter. And they were told, look, if the number hits below 90 or 92%, come back to hospital. And increasingly now with apps through your iPhone, through the cloud, the hospitals can monitor ECGs, etc.
He also sees a place for this type of monitoring inside of a hospital setting.
Not every patient in a hospital is wired up to something. So if they're wearing something that allows them to be mobile but signals that there is a problem before the nurse identifies, oh, this patient's not looking too good.
Even with these advancements, the critical foundation for successful sepsis treatment remains all about early detection.
What we need to do is identify it rapidly, because we can't wait days or weeks to actually do clever immunohistochemistry. So we need the urgent result to say, right, this patient is suitable for steroids, this patient isn't. We've spent 20, 30 years doing large multi-center trials of a whole panoply of immunomodulating drugs and other interventions that haven't worked. And they probably do work in some, but don't work in others, so the statistics don't come out as positive, or they may even harm some subsets. So I think there'll be a lot more of this coming through in the next 10 years, where we'll pick up sepsis quicker, we'll know what treatments are better, both from the pathogen, but also how we modulate the patient's host response, and also interventions to make recovery quicker. So I think that's the future, which I'm encouraged about, I'm enthusiastic about, because I see it happening and it will take off.
The identification, diagnosis, and treatment of sepsis requires clinical judgment based on evidence of infection. Without timely identification and treatment, sepsis can quickly lead to tissue damage, organ failure, or death. Though the main treatment for sepsis is intravenous broad-spectrum antibiotics, overuse or misuse of antibiotics has created an uptick in antibiotic resistance, or AMR. Essentially, the bacteria develop a way to avoid being killed by these drugs. For many years, the mortality rate for patients with sepsis has remained high and stagnant. The future is optimistic, with support from tools such as point-of-care testing, expanded remote monitoring capabilities, and emerging AI-based prediction of risk of sepsis complications. As a sepsis survivor and passionate advocate for others suffering from the disease, Heike Spreter-Krick knows just how important it is to raise awareness around sepsis.
What was just important for me is that we all didn't have sepsis on our radar. Somehow that wasn't in our vocabulary. You only notice it when you know someone who had it, or like me, if you are affected yourself. That was a trigger for me to say, I just want to contribute something to it now, because sepsis has many faces, and we all have different experiences with sepsis.
Also auf jeden Fall wachsam sein.
Be vigilant to the symptoms, whether it's fever, confusion, chills. If you feel really bad, pay attention to it. Inform yourself in advance. What is sepsis? What are the symptoms? So that I can then also recognize the symptoms and then also have the courage to go to the doctors and ask, could this be sepsis?
You've been listening to Healthcare Perspectives, a podcast by Siemens Healthineers. We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. Subscribe to us and always get the latest episode in your podcast feed. Or visit siemens-healthineers.com/podcasts for more. The opinions expressed by the guests and contributors in this podcast are their own and do not necessarily reflect the views of Siemens Healthineers. The statements by Siemens Healthineers customers in this podcast are based on results that were achieved in the customer's unique setting. Because there is no typical hospital or laboratory and many variables exist, for example, hospital size, samples mix, case mix, level of IT and/or automation adoption, there can be no guarantee that other customers will achieve the same results. This podcast describes possible future ideas and concepts. It is not intended to describe specific performance and/or safety characteristics of currently planned or future products. Future realization and availability cannot be guaranteed.